Yep. Can you see my slides? Hello?
Yes, I can see.
Okay. Thank you.
انتوا ما شاء الله عاملين مجهود جامد يعني مش بس في رمضان وحتى من قبل رمضان يعني.
هو ايه الصوت ده يا دكتور راجيش؟ What was this؟
Sorry.
ايه الصوت ده؟
خلي بالك يا رجيش ما بيتكلمش عربي. قلت له رجيش ما بيتكلمش عربي. هو في صوت؟ أنا مش سامع صوت، في دوشه او حاجه؟
خلاص ده عندنا تمام.
آه.
Just 1 second. I'll come back in a second. Okay.
اوكي يا دكتور رجيش، اوكي. احنا كده بدأنا دكتور امير ولا لسه؟
لسه يا دكتور احمد، اول ما يرجع دكتور راجيش يبدا على طول.
Yep.
احنا جاهزين ان شاء الله.
الناس دلوقتي كونكتد معانا؟
نعم.
الناس دلوقتي كونكتد معانا؟
اه معانا يا دكتور.
تمام، كويس.
Hello.
Hello, Doctor. Welcome. There is
Hi.
arrows in the left side. You can click on it.
Arrows on the left side. Yeah. I'm ready. So tell me when you want me to start. I just want to make sure you can
تمام.
hear me okay.
اوكي. اتفضل دكتور احمد عطية، اتفضل.
بسم الله الرحمن الرحيم. السلام عليكم، كل عام وانتم بخير ونتقبل الصيام والقيام. آه، طبعا انا هضطر اتكلم كله بالانجليزي، مش زي ما احنا متعودين في فرانكو ارب، علشان ضيفنا الدكتور رجيش. Okay, good evening everyone. Let's welcome our guest, Dr. Rajesh Phatak. Hoping everyone is awake. Yes, I know this is not very late in Egypt, but it's very late here in Abu Dhabi. We are midnight. Let's welcome our guest, Dr. Rajesh Phatak. Currently, he is a consultant of pediatric critical care at Burjeel Hospital, Abu Dhabi, UAE. Formerly, he is a pediatric critical care consultant, Royal Manchester University Hospital, and Al Hay in the United Kingdom. Also, he is a clinical lead of the Northwest Critical Care Transport Service. He is a main coordinator of the basic pediatric ICU care organized by European Society of Pediatric Intensive Care. He has a lot of working experience with who we can tell you much about it, but just this is just very brief about him. Not worth mentioning that he not only my mentor and the head of the department, he is also an elder brother to me and a dear friend. So let's welcome our Rajesh tonight with his very nice lecture. We will enjoy, meaning war and peace. This is the first part. Second part will be the free discussion about anything you want in the critical care. So share me in welcoming our guest, Dr. Rajesh. You can start now.
Thank you very much, Ahmed. And thank you very much to the organizers for inviting me again this year because I suspect something I did last year was well received. So they have called me again to do it this year. But I want to apologize at the outset because I'm not as well prepared as I would like to be because I was on leave and I came back yesterday and I couldn't devote enough time to do this. But I thought it will be something of interest to perhaps many of the listeners, many of the audience. But if it is not, I do apologize. Okay. And I think before we start, I'm very aware that out of any such presentation, any such topic, any such lecture you attend, most attendees will remember only two things or three things maximum. If you are really bright, and I'm sure you are really bright, you'll remember four things. Okay. So I'm going to make sure you remember two or three things from this session today. The first thing I'm going to teach you is how to make the screen go black. If you're doing a PowerPoint presentation, you can see my slide. The screen is black, but I can make it come back in a second, hopefully. Uh-oh, it doesn't work. Okay. What did I do? Ah, okay. Usually, if you are doing a PowerPoint presentation and you press, oh, it works. Okay. And you press B, the screen goes black. Okay. And this is very useful if you're teaching a small group of students or audience and you want to capture their attendance when you don't want them to look at the screen, but focus on what you're teaching. So this is the first step. I think you'll remember very easily. Just press B and the screen goes black. You press it again and it comes back again. So if you want to make it go white, what button do you press? I think the answer is fairly simple. It is W. Okay, you press W, it goes white. So if you learned these two things, half my job is done already. So we move on to the content of the session today. And this is a very weird title. I'm not going to talk up anything about the book, which Leo Tolstoy published many years ago. I've not read the book. I can't say I'm a big fan, but what I certainly you will share this aspect is we have seen what happens with wars, and effects of it can last for quite a generation, and many of us have uh, lived in peaceful times, but also we are seeing the effect of ongoing wars across the world. But before we go to wars, what happens as a fallout of the wars that we have seen not only in Gaza and Ukraine, but perhaps somewhere else in the world as well. We must think about how it impacts medicine, how it impacts our practice, and what other things that we learn from it. But before we go to wartime scenarios, we must remember a lot of things happen in peaceful times. And when I started thinking about what is the contribution of wars to medicine, I think one of the things that may come to many people's mind is warfarin. But believe me, it has nothing to do with wars. Okay, if you, I think the cardiac surgical team owe much more to farmers than they think they do. So if you know how warfarin was discovered, it is all down to vets showing that the cause of cattle dying from internal bleeding was because they had eaten infected hay and mold uh, containing the hemorrhagic substance. This happened in 1920s, but it didn't really get used to translation to medicine until a US Army recruit in 1951 tried to commit suicide by the same rodenticide. This was used, which was discovered by the Wisconsin Alumni Research Foundation, and they realized this leads to bleeding or thinning of blood. So and they were able to treat it with the vitamin K, and this is how warfarin was discovered and came into use, and we still use it today. Almost every cardiac surgical patient or cardiac surgical team will be familiar with warfarin. And had it not been for warfarin, I think cardiac surgery would not have reached uh, where it is today. So almost no valve surgery would have been possible. So this, what has this got to do with uh, working in pediatric ICU? So I think we work very, very closely with other team members, including the cardiac surgical team, often the perfusionist, the physiotherapist, the nursing team, the ICU team, and I'm very, very lucky to share our not only workplace but also office space at times with very, very good clinicians, very experienced clinicians. So coming back to uh, how war disrupts our lives, of course, it can be a personal loss. Uh, how it affects us. This top thing at the this thing at the top, can I get rid of it, or I don't know? This bar at the top, is it visible to you?
Yes, visible,
Uh,
visible, Rajesh.
okay, I'll
Mm.
try to move it. Okay, maybe. Okay, if this, okay, fine. So with any war, there will be a displaced migrant population. And I think living in Egypt, you probably are much more familiar with this than uh, we experience here in UAE. I've not worked or lived in a neighboring country with a war, but it does put pressure on local systems, and also it leads to economic uncertainty. It causes rota disruptions. We have experienced some of that. A couple of our colleagues going away to help volunteer as a team member in the ongoing conflict in Gaza. It also makes us wonder, are there any opportunities that are created inadvertently? Nobody is advocating warrior, but if something is happening, then I think there may be some areas that we can learn from. Of course, it leads to fragmented education, and this is highlighted by the fact that lots of medical students from, uh, I think, universities in Sudan have been contacting me because I look after trainees and interns in our hospital, whether there are any opportunities for training. And that just can put into perspective how lucky we have been with our own educational systems going back to medical school. Yesterday, I met a colleague who said to me, he's come back from his alumni gathering, and he started medical school in 1974, you know. So this was their 50 years gathering, and he said 76 of his classmates made it to the gathering. And I'm happy to admit I was not even born then when he started medical school. But they are such dedicated clinicians who are still working today and cherish those meetings. So there are lots of publications around, but I'm going to focus a little bit on this particular publication because it highlights what the challenges are through uh, working in a war situation, and also the opportunities presented. Certainly, the patient population is very different. The number of severe trauma patients will go through the roof, but it also leads to the more stable patients usually not getting access to primary care. And something we have seen previously in the context of COVID, children not getting access to simple coughs, colds, and fever, and presenting very, very late to the emergency department. Uh, and what opportunities may arise from this? I think there is definitely unwanted opportunity to get competence and experience in fields that we have never experienced before. This is the right time to use technology, to use telemedical consultations, and even live surgery consultations with ongoing surgery for difficult cases has been used. We've seen and triaged patients who can transfer to specialized centers. And a colleague of mine who is currently away on Umrah, he has been to 2 trips to get across patients, some of them unstable ones, to get across for ongoing treatment. So one might say they are the lucky ones. At the heart of it, working in ICU, I think safety is always a concern. So one needs to remember that we need to organize ICU in a safe shelter away from all the action. Need for simple things like electricity installation. Attacks on infrastructure means you can't do any of the activity on ICU that you would otherwise do. Uh, so medication, water, simple basic needs have to be met for clinicians, staff, and also patients. So if any of you has ever come across a fire in ICU, I think that will highlight to you the problems of working in an environment like ICU. One of my colleagues was brave enough to literally put out a fire. This was in 2014 or 15 at Audrey, but we were extremely lucky it didn't spread. And had it spread, who knows what fatalities we hospital would have ended up, because it is not very possible to move all the patients. We are talking 15, 20 patients, sick patients, ventilated patients in ICU, some post-cardiac surgery, some body on ECMO, somebody post-neurosurgery. They're not going to be able to disconnect from equipment and just move out. So planning for something like a fire on ICU is really important. Having a fire plan is important. And if you work in an environment in a hospital or with the ICU, then I think having that plan on paper, doing a tabletop exercise as to what should be done, who should do what, is very important in this situation. And this is a peacetime exercise, nothing to do with war, but I think uh, having that thought process will allow us to have a safe plan to evacuate in the never event like fire in ICU. So what opportunities it creates is equipment and medication checklists for every critically ill patient, providing humanitarian aid. Often we see clinicians come out with not only clinicians, vast sections of society will come up with humanitarian aid. And of course, selected patients can be transferred abroad, either in the same country or even abroad for further treatment. Um, I think one of your colleagues has raised a hand, but we can uh, go to questions later on, I suppose, if that's okay. But if somebody has a burning question or comment to say, you can go ahead. Uh, do you want me to stop to let somebody ask a question? I don't know. Or should we come back to them later? Dr. Ahmed?
Proceed, dear Professor.
Okay, okay, thanks. Okay, so one of the key issues that any ICU will deal with is pain management. And I think long-term pain is what we are used to treating in ICU. But if we have thousands of patients with acute pain, I think chronic pain is going to become a problem in a vast majority of them. We have lots of patients who require rehabilitation. Many more will have mental health issues like PTSD and some other issues as well. I'm not an expert in mental health, but I think somebody who knows about, who is well versed with mental health can educate us on this. Of course, there are insufficient patient and personal education and lack of, standards go literally out the window. There is inadequate acute and chronic pain services and funding. I mean, where do you start with funding? The funding, it's a bottomless pit. I think all healthcare economies will have stresses which are multiplied in the event of a war. But the opportunities it may present is one could get across standardized pain management, development of new rehab centers, better family-centered education, personnel education, and hopefully uh, acute and chronic pain services can be organized. This is something that we have experienced in one of our units, the challenges with deep soft tissue infections and difficult to treat osteomyelitis in blunt trauma patients, in blast injuries. We have seen this also in patients who were injured in the Manchester bomb blast. We looked after them in the ICU in Manchester. And not so much of heterogeneity, but I think the doses of antibiotics used in different conditions in different hospitals uh, can be a challenge in itself. So the opportunities obviously are if we can get around and produce a national uh, antibiotic therapy standard, that will help. And I think it brings forth experience in the treatment of blast injuries and associated soft tissue infections. So telemedicine, I'll refer again to this. So systems development within and outside the country. If you remember what I mentioned in the last year's lecture, Dame Sully from the UK on the BBC, one of the videos mentioned that there were more deaths in World War I from infections than from injuries themselves. So I think difficult to treat infections are uh, it's possible to treat only with antibiotics. So they are a very, very protected resource, and using them left and right is not going to help us. So these were the most common bacteria causing infections in war injuries. The usual culprits are Pseudomonas, but also interestingly, the staph and strep. These are bacteria who I think don't get enough respect. Certainly in previously well people. And yes, E. coli is also figuring in the top five. But with a resistant wound infection, the mortality went up to as high as 12%. So 1/10 of all people with resistant infections ended up dead. So they have mentioned some potential solutions. Which I mentioned, a national antibiotic therapy standard, documentation of antibiotic stewardship, prevalence of resistant strains at the national level, and also education and telemedical consults within the system. So in brief, this is the paper that you may wish to look at if you're interested. And of course, there are many more. And I think what these authors have highlighted is progress made with the help of international colleagues, one to evacuate patients and to plan treatment, surgical therapies, and immense possibilities for education. And I think this team and the organizing team is making use of telemedicine for teaching already. And I hope this has been a somewhat useful exercise for anyone attending. But going back to previous wars or previous uh, use through the years, as far back as 2009, this is probably after the Gulf War. Um, they have reported use of multiple intraosseous catheters in combat casualty research. So this particular patient or soldier was injured, and they put in 4 intraosseous devices for this patient who was resuscitated and transferred to a treatment facility. And I don't think, and the paper goes into great detail as to where they put it and why they put it and how they were able to rescue this patient, salvage him till the point, but it was not a survivable condition and the patient passed away. But the learning from this is using our devices not only in a blast scenario, but often in critically sick patients wherever they may be. And certainly this is one advantage that we have borrowed. So I'm just going through the IO sites, and you are all are probably very familiar with this. But if you're not, just go through this. Um, and it helps us. The most commonly used ones in children is the proximal tibia, mainly because people are unfamiliar with other sites and uh, they are not, and they feel comfortable using the proximal tibia. But I also have used the proximal humerus in a patient as being the only access site. The patient had a critical coarctation, uh, a neonate, I think 4 or 5 day old baby, 2.3 kgs, came to a peripheral hospital, completely shut down. And our job was to resuscitate him and take him to the cardiac surgical center on a prostate. So we put in 2 IO devices that can be done very, very quickly in a matter of minutes. Uh, Tubed him and took him for transfer. That made the whole process so much better, so much quick and safe, I must say. Okay. I don't think I've used the distal tibia. I've used all other sites in patients for intraosseous access. So the only thing to remember, I'll try to move this, is uh, uh, the patient shouldn't have had a previous IO in the same bone in the previous 48 hours. The only contraindication is infection at the local site if it is accessible and secure to monitor that site. These are the only things one needs to think about when securing IO access. It's usually a short-term thing, usually 24 to 48 hours, and I still feel they're underused in medicine. Okay. So just going through the proximal humerus site, locating it, and making sure we rotate the arm inwards, palpate the surgical neck, and locate the insertion point. And once we do that, we can secure the needle at a 45-degree angle, pointing slightly downwards. So there we go. And this can easily be done in under a minute. So guidance for adults is to use the 45 mm needle and to advance it 1 to 2 centimeter after the field through or the pop. Okay. The proximal tibia, as I said, is the most commonly used site in children. And if you have not done it, I would definitely recommend to look at videos on YouTube or any which way you want to get training. It's definitely a skill to be acquired. So There are 3 needles available from the manufacturer, and I think 3 to 39 kgs is wrong. We have used this needles in babies under 10 kilos, under 3 kilos. So I think anybody above 5 kilos, you're going to need a blue needle. They are the wrong way around in terms of sizing. Cannula, you'll know that cannulas, 20 French, 20G cannula is pink and the 22 is blue. But in terms of IOs, it's the other way around. The blue one is the bigger one and the yellow one is even bigger. So when we do cannulas in babies, they're usually yellow, 24G, but the IO needle, the biggest one is 45. That is the adult one. And we don't have to particularly go in all the way, but we have to make sure that it reaches the cortex. So, and a drop of blood is available. Otherwise, you're not going to infuse inside the bone. You're going to go into the subcut. This is the subcutaneous area, and unless you go deep enough, you're not going to infuse in the bone. Is IO needle painful? The process of doing it itself is not terribly painful, but the flushing, if you push it very fast, that elicits pain in the patient, and using 1 ml of lignocaine IV is probably a very, very safe thing to do, and that will help get rid of. But if the patient is shocked, then they're not going to complain what the problem is either. They're not going to complain. They don't feel the IO being done, they're not going to complain about the flush either. Any idea what this is? This is the sun signs, and I'll tell you why I came across this. Okay, this is commonly used in India for matrimonial purposes. So one of my cousins, she asked me, her son is from marriageable age in his late 20s, and they are seeking prospective alliances for him. So uh, this is the star signs and how many stars should align for a marriage. So she says all the stars have aligned, but one question I have in mind, if the prospective bride is rhesus negative, are there any medical conditions that we need to worry about? Okay. And I started thinking this is a very weird question. So nothing like this I've faced in, I'm not been asked to think about this particular aspect ever really. So I said the only problem you might need to think, I didn't know this was a thing until this I was asked this question. And then I looked up something about RH pregnancies, not related to our day-to-day work, but very fascinating to see. This is a case report from Mumbai, not a million miles from where my cousin lives, uh, to say that they have done the first intrauterine transfusion for a triplet pregnancy, uh, and it has gone on well. So all 3 triplets received, I think, intrauterine transfusion, and after they were born, they received intense phototherapy and immunoglobulin. So ultimately, I went back to the person posing me the question, and I said, "Don't worry about RH, incompatibility, and all these things in the bride. If everything else matches and the bride is good, then please go ahead. Don't let this be a bar for any matrimonial matching." Another question I was asked from, and I'm sure you will be asked these questions by patients, by neighbors, by colleagues, by nephews, by aunts and uncles. So one of my nephews had a baby. He lives in a very resource-rich environment in the US. And the question was, what do you think we should do if the infant does not pass he's had a baby girl, and the baby didn't pass stools for the first 3 days after going home. She had passed meconium on the first day before discharge from the hospital. This is the first baby. And the questions commonly asked in MCQs Usually, we'll talk about doing an abdominal X-ray, examining the patient, checking thyroid functions, but of course, examining the baby's anal opening. If there isn't anal opening, then the baby is not going to pass stools, particularly in females. I've seen a 7, 8 month old baby girl. This was a long time ago in the UK, presented with a vaginal fistula. Uh, and I think the patient was a rectal fistula. So it was a common cloaca, it was an anorectal malformation, and the patient had no anal opening, but was passing stools for as long as 6, 7 months through what was the fistula opening, and nobody had bothered to check. Uh, of course, this little girl organized appointment with the pediatric gastroenterology to organize a rectal punch biopsy. But on the way to the clinic, my cousin sent me a text saying she's passed a huge amount of stool, and I don't think we need to do it. But I said, okay, you made an appointment. If you want to go ahead and do it. And they did it, and thankfully everything was fine. So this just goes on to show our actions will really be dependent on the resources available to the patient and to us. So I'm just going through a little story. A patient we had, I think this was in September, a 16-year-old girl
Dr.
who
Rajesh,
presented
Rajesh,
to the ER, uh, fairly sick with shortness of breath, chest pain, and a fairly acute history, cough, fever for 2 days. And many families have had oxygen saturation monitors at home. And only because she looked unwell, the father checked her saturation, and to his surprise, it said the number 86. So that frightened him, and that is the reason why they came to emergency. Uh, to
sorry
most of
for
the clinical
interruption.
team, hello?
Rajesh,
Yeah.
sorry for interruption. Sorry, can you raise your voice a little?
Yeah. Am I okay? I'm
Okay.
sorry you can't hear. Am I audible now?
For me, yes. For me, yes. Yes.
Okay. Uh, is it because I'm using headphones? Should I get rid of the headphones? Let me try without it. Is this better?
Yes,
Yes.
it's better, doctor.
Yes.
Okay,
Yes.
I
I
will
can.
get rid of the headphones. I don't know where the problem was. Maybe the mic wasn't working there. Anyway, um, I'm sorry if you couldn't hear me well. I hope this is reasonably audible now. Okay. So this is the story, and nothing alarming there except for the fact that oxygen sats on arrival to ER were quite low. So no significant past history. Uh, the family has 4 other siblings. They all had flu-like illness in the last 4 or 5 days, but they've all recovered with symptomatic management, but not this particular patient. She has remained unwell. And I think those numbers tell a story. A 16-year-old with tachycardia of around 145 has to be fairly sick. She's not breathing that fast. Luckily, she's not hypotensive, but has already subcostal retractions and intercostal retractions, fees, and creps. So we all think this is a fairly sick patient, and luckily she's come to a hospital with a good ICU, with raised inflammatory markers, with a CRP above 200, procalcitonin 40, and profound neutropenia. Her white cell count is only 0.69. Though luckily her platelets are nearly normal. So something is going well. In view of her chest pain, I think all these bloods were checked, but the most worrying thing for ICU clinician would be the lactate of 6 or 5 or 8. I mean, that's a very sick patient. And X-ray shows right-sided, a patchy area of consolidation in the right, mid and lower zones. So uh, what would we do for this patient? Well, this is what she as we already plan for respiratory support, start her on antibiotics, think about vasopressors, send a group and cross match, and monitor her initially on high flow oxygen, then an IV, and then escalate very, very quickly to intubation because we are probably dealing with ARDS like picture. And she was admitted roughly around midnight. And by 10 o'clock, her gases had worsened to this sort of situation. So try to ignore the one on the right. Just look at this particular blood gas. And you can see she's fairly acidotic. CO2 is high, but not terribly high, 50. PO2 is 80, quite low. In 100% oxygen, and with a base excess of minus 15. So with a lactate which is climbing at around 7. So at this point, we really need to think about the patient is already intubated and ventilated, a PEEP of 12, it says there. So fairly good going ventilation, FiO2 to 1. So there's not much to room to maneuver at this stage. And we had a team meeting and decided to initiate BV ECMO for her because our SATs already at this time were in the 80s and they immediately improved as soon as cannulation was done. And this is our X-ray immediately post cannulation. So the couple of things I think you will note, and this is something certainly this patient has benefited from, is the left IJ CVL. So when we are securing central lines for critically sick patients, we have made it a habit to uh, think about ECMO as a possibility in every patient we intubate. So we it's not a written rule, but it's what we practice. And I can say that the one patient who will benefit is the patient who ends up on ECMO. And I think no other patient will come to any harm because we use the left IJ as opposed to the right IJ. Femoral veins, yes, we use occasionally, but in very, very sick patients, it's much easier to use the IJ veins. And between the left and right, I think for obvious reasons, the ECMO cannulation is always going to be in the right IJ vein. So if your cannula is already there, you'll need to put another one. And this just saves a lot of hassle and time for the patient. So you can see the left IJ line, which is well placed here, very close to the heart. The ET tube is well placed. The NG tube with its tip, I think below the diaphragm, but may need to go in a bit more. And ECMO, this is VV cannulation. Okay. Oops. And we can see the ECMO cannula going right through. It usually has a couple of outlets in the right atrium, but also suction port at the distal end and the proximal end. And these are done with echo guidance. I have the images for the echo when we place the cannulas, but I have not put them in here. And she had a good ECMO run of about 8 days. Her white cell count improved, platelets, which were initially normal, fell down to these numbers, mainly because we suspect very strongly consumptive coagulopathy. The circuit itself will gobble up platelets, but thankfully her infection number started to settle down. Her PCT, which had been 40, then 100, came down quite nicely. And thankfully, her renal function also improved with time, and she did not need renal support. She did have one complication, however, and this was we initially thought it could be possibly due to arterial line in her left hand with duskiness here of the fingers and going on to have a little bit of a scar and ischemia here. But after, thankfully, before removal, we were guided to inject some papaverine intraarterial and also local altiplase through the line before removing it. And luckily, all these lesions healed very nicely. The panel that we used grew strep pyogenes, and what I didn't go into details was her vasopressor support. She was requiring a fair amount of vasopressor support on norepi and epinephrine, and then we switched to vasopressin on day two, no, on day one itself. So there are a lot of time spent at the bedside mulling about whether we need to move over to the ECMO in light of the rising lactate and a fairly high vasopressor requirement. But thankfully, she continued to make progress. We are able to wean the vasopressors and turned it off, and ischemia in the hand recovered very nicely. She was discharged from ICU on day 10 and from the hospital on day 14. She's made a good recovery, and on follow-up in pulmonology clinic, she had very little in the way of findings. Her labs are returned to normal, and she's gone on to lead uh, a decent recovery life. This is not what we can say for all ECMO patients, and I think we're incredibly lucky to have the right team around at the bedside for this patient. So the timing of initiation of ECMO is not really defined in and it differs to some extent from center to center. When I say it is not defined, that's not true. It is fairly well defined. If you see any of the guidance on ECMO from the ELSO registry. But what we don't want to do is change from a VV to VA ECMO, particularly in the face of cardiovascular dysfunction. So if we have to do it, yes, there might be a number of reasons that a patient may require from VV to VA. The hypertension may be due to pulmonary hypertension, RV failure, and any or all of these causes. So I think we need to be very, very careful about titrating mechanical ventilation and let the patient, the ECMO circuit do its job, because escalating ventilation has detrimental effects to cardiovascular function. So yeah, and we don't want ECMO because increasing risk of bleeding and systemic embolization, which you are able to avoid with this. And I very strongly suspect this. Well, we know this patient had group A strep septic shock, and the only reason why we are able to avoid via ECMO and have a good outcome is we did not thrash her cardiovascular system, because we are able to initiate ECMO in a very timely manner, and this allowed her to have a good recovery and a good outcome. This is not our patient. This is a patient who sustained bilateral amputation. I think on the 27th of October last year, and in the media there were reports about her having been evacuated to hospital in Chicago, and she wants to go on and pursue medicine. And I think that's a great story to end on. So I'm done. Yep, all yours. Am I audible?
Yes, Dr. Rajesh.
Yeah.
Thank you. Thanks a lot for your kind presentation with such diverse ideas. Now is the time for questions in your presentation or any ICU
Yeah,
related
of
topic.
course. Yeah, you can ask.
Yes, I think there was two of our colleagues raised the hand during this, Dr. Sabri and Dr. Shaimat. I don't know if they are still with us or no. Dr. Sabri, I think yes, he is here. If he can hear me, you can ask your questions if not already answered. Okay. Okay. Dr. Shaimat? Yeah. Okay, I think they already either went or I think they are still here, but maybe they have
That's
their.
fine. That's fine.
Okay, you are ready to accept any other questions from our audience? Is Dr. Muhammad Hamid, mechanism of ECMO?
Mechanism of ECMO. I think that's in succinct detail. I think it does the work. So VV ECMO will do the work of the lungs, and VA ECMO will do the work of the heart and the lungs. So any ECMO circuit will have its extracorporeal, uh, circuit. Blood is taken out from the body, goes through oxygenator and a pump, and goes back to the patient. And that's the basic mechanism of ECMO. And unless you seen one, I think it's very difficult to get your head around. But of course, there's a lot of published literature on this. But you'll need a lot of training to at a bedside and practice to understand what really needs to be done when initiating ECMO or continuing a patient on. Put a patient on ECMO is relatively easy if you have a cardiac surgeon next to you and a perfusionist. But a lot of ICU teams have taken on this role as well, certainly for adult ICUs. Uh, many adult ICU physicians are now ECMO physicians doing VV cannulation. So any IJ vein or femoral vein can be easily cannulated. I say easily, but the more you do, there are people who have done 100 ECMO cannulations now in ICU. Somebody's asking sites of intraosseous injection and cannula sizes. Okay, so cannula sizes is very simple. I'll just go through this slide again. Okay, so in babies, I would use in 3-4 kilo babies, I would use the pink one, and anyone above 3 or 4 kilos, I would use the blue one. Mainly because as you can see, the pink one is barely 6-7 millimeters. It's not really going to reach in the bone, and you have the risk of causing extravasation of fluids. And just having that little bit extra around 10 millimeters comes in the pack, and just doing it. Once you've done it, you'll realize how easy it is. We did one recently for one of our patients in ICU who needed ventilation, who had lost IV access, and he was just thrashing around, and we were not able to gain control. So in a matter of 30 seconds, we're able to get IO. I usually go for the proximal tibia because that is the easiest part in babies, certainly in chubby babies, that is possible. And for correction of dehydration, we used one with good success, as my colleague Dr. Yasser will attest, for a patient who came to ER with dehydration and shock. Yeah.
Dr. Mahmoud is asking about can we use high frequency ventilation instead of ECMO?
Can we use, sorry?
High frequency ventilation instead of ECMO.
Well, I think it will not do the job of ECMO. You can use adult units don't really use high frequency ventilation. High frequency ventilation will buy you some time maybe, but in scenarios like this, I don't think high frequency ventilation will be enough to avoid ECMO. So ECMO is certainly done for oxygenation failure, and or so no amount of so what will happen in what I've seen happen in these scenarios is the patient will get onto high frequency, fairly high maps, they develop pulmonary edema, and respiratory failure turns slowly into cardiorespiratory failure. So you got a completely deranged cardiorespiratory system, and we go higher and higher on pressures, higher on your mean airway pressure. You're already FiO to 1, increased vasopressors. You feel the patient's VP is already 12, 14, 16. So I think there is recognition that high frequency is, or just ventilating the patient harder is not the solution. If you have access to ECMO, I think the sooner you make that thought process in your head, the earlier initiation of ECMO will help the patient. If you have access to it, I'm not saying all patients will have access to ECMO, but I think more and more centers will, in the next 5 years, have access to ECMO.
I think this is the problem mainly, yes, it would be the availability of the service itself. Because in Egypt, as far as I know, there is no organized ECMO, respiratory ECMO. There is VA ECMO, VV ECMO used usually in cardiac centers like Aswan Heart
Yeah.
Institute. But I'm not aware of pediatric critical care units with regular use of ECMO
It
for.
will happen in the next 5 years, I'm sure. I mean, it's happening
It's
already in
ongoing
India.
evolving programs, but
Yeah.
maybe some of my colleagues can tell me if he more updated information. But I think general ICU units till now there is no ECMO. Adult we have many years ago started already.
It will come. It will come.
Yes, yes, of course. It will. But I know there are many units, even in developed countries. There is some district in Germany. There
Oh,
are some
yeah.
people from them. They don't have any access to ECMO, or especially in pediatrics, they are using very high pressures in high frequency. Sometimes.
Yes.
But the problem is if the patient is beyond 8 to 10 kg, the true high frequency ventilation, which is piston derived, is only available in sensor medics ventilator. All other
Yeah.
hyperventilators usually
Yeah.
using is interrupted diaphragm technology, which is not
Yes.
truly high frequency if used above 8 to 10 kilograms.
Sensor medics have stopped manufacturing that ventilator, high frequency ventilator, the noisy one now. They stopped
Yes, yes.
manufacturing it now. So, and I don't think they will start manufacturing because that market is dying. And I think the ECMO market is booming, certainly in many countries, particularly in Europe and US. So, many companies are devoting their production towards ECMO. There are many more ECMO machines available now than there were 10 years ago, you know.
Yes, of course, yes. Dr. Sabri is asking when must consider the Acinetobacter in the PICU.
Ooh, um,
This is one of the very famous organism now in the units.
well, Acinetobacter baumannii, I think, is the organism that can be pan-resistant to many antibiotics, almost all antibiotics. When should we suspect it before getting a culture result? I don't know the answer, but I think it lies somewhere along the lines of if the patient has had multiple bowel surgeries, is one of them. Patient is on TPN, has lived in an institute for a share of time, has had invasive devices like a tracheostomy, PEG tube, or urinary diversion, or some such thing, and has already had exposure to antibiotics in the hospital. I think those patients are probably likely to be victims of Acinetobacter. If anybody else has any other tips in this regard, I'll be happy to share. But usually, Acinetobacter is an organism. I mean, any of those organisms we can suspect, but ultimately we have to grow them in culture. So we yeah.
What's your experience about ceftazidime azobactam?
For Pseudomonas, I think so. All the higher antibiotics, I think, we tend to reserve for culture-proven sepsis. If there is no uh, organism identified on culture or without a sensitivity pattern, we would be very reluctant to use antibiotics of this nature. We have used ceftazidime, avibactam. We've used it a couple of times, I think, but not more than that. Adults use it for Pseudomonas, and I think our colleagues have shared this experience. Maybe it's as good as any other antibiotic combination, newer antibiotic that's available in the market. I can't say whether it's any better or worse than whatever else is available.
Dr. Sabri looks like he is dealing with very septic patient currently. That's why he is asking two questions
Yes,
about.
yes.
Uh, Yes,
I
this
mean,
is very
this
clear in
is
the ICU, actually, yes.
I
The
mean, this is a
organization
problem. This is a growing problem,
yes.
and I don't think an individual clinician can tackle this. This needs action at a much higher level, if not at a national, but particularly at a local level, to have some guidance and data available to reinforce to clinicians about the risks of an antibiotic resistance. So what is the cutoff for platelets transfusion for patient in ICU without bleeding? Okay, so there is a very good document to answer this question. I will share that document. I think that's from the pediatric cardiac uh, pediatric critical care. I think published last year. We discussed this, I think, earlier in Jan or Feb 24, I think. The bottom line is uh, I think don't use a platelet number to decide whether we are going to give a transfusion or not in itself. It depends on the risks. So risk stratification depends on, is the patient post bone marrow transplant? Is the patient septic? Is the patient having any bleeding? You have said no bleeding. So, but there may be, or is the procedure plan? Are we going to do a central line or intercostal drain or something? Because the threshold for that will vary on two things: patient factors and what we are going to do. If you're not going to do anything to the patient, no surgery is planned, the patient is hemodynamically stable, we might accept platelet count even about 20, even 10, 15, 18, depending on what the trend is. If it's a chronic and what we think is causing the low platelets. So certainly if the patient is having multi-organ dysfunction, I think that's a different patient. So patient is on dialysis or ECMO. I think for this particular patient on ECMO, we had chosen our cutoff was, I think, to try to maintain it about 30,000 because we're not actually doing any procedure and there was no bleeding from any side. Even the cannulation side, there was no bleeding. So yeah, I will send you that document, and in fact your transfusionist or your pathologist will thank you for two things: not transfusing too many and not asking for group specific platelets. So that is the two big take home messages for platelets.
For this document, I will share if Dr. Rajesh will then share it here. I will share it on our group. It will be very nice. It's comprehensive. You can see the patient, condition, your
Yeah.
plan to do, transfuse or not, and it's in numbers. So it will be easy. Although exact number will not be that the
Yes.
best way to decide, but it's should be considered that. So
Yeah.
sometimes you need a clear yes or a clear no, which is very rare in medicine to find such type of answers. But
Yeah.
in this document, you will find 90% of answer.
It's quite a useful document. Yeah. Yeah.
Yes, yes. If you have access to it now, Dr. Rish, you can share. If not, you can send it to me and I will share with them on the group.
Yeah. I don't know where it is, but I have it somewhere. I'll send it to you tomorrow.
Okay.
Do we have any other questions?
Okay, I think we are done for tonight.
Thank you so much for having me.
Thank you for attending, Mr. Rajesh. I know you are sleeping early, so we are very thankful that you stayed that late. Thanks a lot for our colleagues. Hope you enjoyed this lecture. It will not be the last one. كل عام وانتم بخير، تقبل الله الصيام والقيام، وان شاء الله نتقابل قريبا ان شاء الله. هتكون محاضرتنا الجايه من ناحيتي انا يعني ان شاء الله هتكون عن الشيست CT. هي كان المفروض تبقى في رمضان بس بعض المشغوليات تاجلت، يعني ان شاء الله بعد رمضان هتبقى عن الشيست، هاو تو انتربريت شيست CT فروم بيديتريشن بوينت اوف فيو. وبالتوفيق باذن الله. تصبحوا على خير.
Thank you.
Thank you, Dr. Rajesh.
Thank you.
Thank you, Dr. Ahmed.
شكرا
Good night.
جزيلا. السلام عليكم.